Today's talk, we're going to have a chat about macular degeneration. Big topic in one sense, and we're going to just have a brief overview what it is, what to look for yourselves, for us as clinicians, and the treatment and prevention that's about there today. One thing we do know, it's the most common cause of visual loss. It's affecting at the moment about 1.5 million here in the UK, and 12.2% of those are over 80 years of age. So for those of you in the room that are over 80, then you'll find your peers, etc., will start developing some form of degeneration of macular changes. And we do know with the aging population, we're going to see about a 60% increase in this over the next 10 years or so. So everybody talks about the aging population, and I think with that in itself will result in impacts on us clinically, our NHS services. So it'll be interesting how they go about treatment modalities and changes over the coming years. And I'm sure that's why they'll be looking interestingly at clinical trials and ways to get to the root cause of this. Detecting AMD is, patient symptoms are often one of the first things we'll notice. They'll say to us, oh, I've noticed a drop in my vision. I'm struggling now with my small print. Lines are becoming a little bit wavy. Some people will present with a sudden patch over the vision. Some people, interesting enough, present with no symptoms at all. And I think sometimes it's amazing if you've got very good vision in both eyes and you've gotten along with things, you'll sometimes not notice that your vision has dropped off. And it doesn't happen that often, but people do present to you with it, and you come across it accidentally when you're assessing their eyes. Detecting them, obviously, if you can detect it, you'll notice something's wrong yourself. Most people will present. Some people don't present. But I do think people are becoming more aware of their eyes more and more nowadays. What is helping us in practice is equipment has advanced massively in the last few years, 10 years. So, and with that, a lot of us are now able to invest in equipment that would only have been possible in eye departments. So imaging, the mainstay of imaging is taking photographs of the eye, but now, of course, the only way of detecting it clearly and which layer has been detected in the eye is through OCT. So OCT is called optical coherence tomography, and it's this image here. These are our routine images, which can be this size or wider. But obviously the OCT is now telling us where the problem is. So it's some people who may come in with some of these symptoms. It's not necessarily wet. They just have significant changes going on in these layers, which are normal with dry degeneration, which are normal with other things that can go on. It's not just macular degeneration. You can get changes that occur in the gel of the eye that causes this area to pull up a little bit. So you can get other things that may give symptoms similar to it, but aren't that. And it's the OCT has completely changed the landscape of how we can monitor, spot, diagnose, and know exactly when to treat people. What is it? It affects the central vision. So this is the optic nerve, where the nerves come out and gives us our side vision. This bit here is our macula. It's the main area where all our cones are concentrated. So that's why you see a dip, because it's what we call the fovea. And this is a patient with, I would have said mild to intermediate starts of dry degeneration. This is caused by these yellow deposits that we see when we look into your eye, which we call drusen. And it's for us as clinicians to kind of work out at what stage we think you are in the process, and at what stage then we want to look at how we look after you. So for the person with fairly severe degeneration, this will be those of us lucky enough to have normal vision. And those of us who have significant, we are losing the central part. So you've got patch in front of your vision, which is how this is demonstrated here. We know there's two types. There's dry and there's wet. Dry is where there's, we use the words wear and tear, degenerative changes that have occurred with time. And we do use the word, and it's not age related for that reason, because it is something that it's the majority from those 50 through to older life that get it. Wet often comes from dry, but it can spontaneously start on its own, and it's where then you get fluid, subretinal fluid in this area here, which is what gives the patch in your vision. You can imagine this giving a patch in people's vision. Dry, what are the causes? I'm sorry to keep using the word age. We know it's one of them. Smoking, a biggie. We're smoking a lot less now. It is a 4 times risk with smoking. Sunlight exposure. There's probably a little bit of limited evidence there, but definitely sunlight exposure is one. Genetics is quite a strong one. First degree, so close family relatives with macular degeneration. Always worth flagging that up with your optometrist if you think you're seeing them. Even if you've got younger members of the family, just say, look, when you say it, just make sure they keep it on the radar when they're looking at you or assessing your eyes. Genetics with a family history and smoking, you really are in the firing line. You're 20 times, I'm afraid. So if that's any of you here, I'll talk about this in a bit more detail. Thus, I've got the little basket in front of us here. Inflammation and poor diet, of course, we know isn't just for our eyes, but can cause chronic illnesses throughout our body. Within the eye itself, what's going on? Well, the eye, this area back here, you've heard of it, or many of you have, our photoreceptors, our rods and cones. These can just naturally get damaged. So they fall off and we lose them over time. We then get damage to the membrane further back on the eye. It's called Brooks membrane, if you need to know, but that membrane is quite good at it loses its conductivity. And what I mean by that is its ability to transport nutrients into the retina. And we will come back to this word nutrients into the retina a lot today. And so it loses that conductivity. So that's another reason. It just naturally loses that ability to support the retina. Oxidative stress. This is a common occurrence. This is occurrence through our whole body. And it's just basically where the level of good guys and bad guys, the antioxidants which are there to support our eye, is not in balance with what we call the free radicals, so the inflammation in our body, the smoking, the UV. And I've put a scales there. I should have got one that tilted a little bit more, but we really want lots more antioxidants, lots more nutrition, lots more reduced inflammation to combat the free radicals that keep getting us all the time. And that's very, very important. So we need to alter that balance. And if not, if that balance is tipped the other way, there's a lot of oxidation going on in the eye, a lot of radicals going on in the eye, and a lot of environmental impacts, smoking, chronic other illnesses, then the further damage to our retinal cells can occur. Wet AMD, as I've said, is abnormal blood vessel growth beneath the retina. It tends to develop suddenly, and then with that, leakage occurs and fluid moves into the space and causes this. And if left untreated, which, as I said, OCT has enabled us to look at this in the last 10 plus years, but if left untreated, which you do come across patients, that you then, of course, scar tissue develops. And then that's where people, far less today, thankfully, lose their sight completely. We see very little of that. Previously, we would have dealt with those people with laser surgery, etc. But now, with the onset of treatments for wet, we can deal with that, which I'll talk to you about in just a moment. But in a nutshell, it's just abnormal blood vessel growth, and they leak there. The treatments for the wet, it's the protein, the abnormal VEGF that is the problem, so we need to combat it. So anti-VEGF injections are given. Our common ones that we're using in the country are Avastin, Lucentis, and Eylea. Avastin and Lucentis are the drugs that have been licensed and approved. Eylea hasn't been licensed, but due to some issues that it had with it, but it's been used pretty much locally and around the country because it's known to be equally effective, but more importantly, a hell of a lot cheaper and with no problem. So the Eylea tends to be the one that's used if someone is presenting with vision of 6/12. Let me put that in perspective for you. In my room, or when you go to your optometrist, it's the kind of driving line I call 6/12. You know, kind of halfway down through that chart, or depending what chart they use. That's it. And the reason that Avastin can be used, because that vision is still pretty good. Of course, it's protecting that person's independence, driving, moving around. If they don't live in a town, it's allowing them to drive. So the idea is we can treat people maybe earlier than it was required to do before. Instead of waiting for everything to go wrong and the retina to be in a mess, we can treat them a bit earlier. So having this drug is what's been used. And I say this is the local protocol. The injections tend to be, if you do suffer or get wet degeneration, they're bi-monthly injections here for the first year, and then it'll be regular monitoring. You'll go back in, they'll see you. How is it looking? Is the retina back in its normal shape, or is there still fluid in there? If there's still fluid in there, they'll retreat. Same again, you'll go back in. So it's regular monitoring until stable, but it does turn out that those people who start injections, it's an ongoing process. There is newer drugs been looked at very closely and nearly there at the moment, and I think we may get approval in the next year, is that the injections, instead of being at the shorter duration, we'll be able to stretch the injections out to 16 weeks. So you can imagine the difference that will make. If we've got a growing population and we're clogged up down there, we're trying to see people with injections, if you can spread that out, you're going to reduce the people needed to be in the clinic and be able to hopefully see more. So I think from, again, better, and it's better for the patient, the carer, everything, and obviously the NHS generally, so people be able to receive the treatments in a timely fashion. Dry, well, what can we do for dry? Many of us in clinic, and many of you patients may have dry degeneration. What's the mainstay? Regular monitoring by your optometrist is just very good. He or she will hopefully identify the severity of the degeneration and will make a call. Do I see this person 6 monthly, annually, every 2 years? Imaging is very important. We've just shown you the imaging because we can tell the amount that's going on. We can see the type of degeneration. You can grade it then. Is the drusen, are those deposits small? Are they large? Do they look soft? And all those things are markers for us optometrists to say how severe it is and what's the likelihood that might go over to the other side and change to wet. Home monitoring, I may have said to you, I often say, look at the edge of a picture and tell me, is it straight or does it wavy? Some of your optometrists may give you grids, a little Amsler grid with lines on it, and to look and see, as you look at the dot, is it normal? There's a new app that's now been trialed here locally that you can use, and you can self-monitor at home as well. And that's seemingly a little bit more sensitive to change than the old-fashioned grid, which has probably been out, I don't know, 50, 60, I don't know how many years, but as long as I can remember. So coming back, we know now it's important to catch early. UV protection, we've said about earlier on, what are the risk factors? If you're outside, having a cap, it's good, but doesn't get rid of all the scattered light and the reflected light. So having a pair of sunglasses that are fairly decent, that reduces the reflected light, polarized preferably. Contact lenses are available. Most of them now have got UV blocking on them. That's one. Nutrition, we talked about that membrane, not allowing, losing its conductivity, not sending not sending nutrients through. So we've got to do something about that. So we've got to, as I said we've got to keep the balance of the antioxidants versus the free radicals. So to do that, what is the role of antioxidants? Well, we know where we can get them. We can mainly get them, nutrients have excellent antioxidant properties. And as I've said, they can balance out this free radicals such as blue light, smoking, environment, inflammation. What nutrients can help? All the vitamins, vitamin E, almonds, I think I've got some there, I do. Zinc, where can we get that? In our meat, shellfish, seeds. Omega-3 essential fatty acids are very good for us. Not just are they good for antioxidants, but they also have good anti-inflammatory abilities. Salmon, walnuts. Vitamin C, our broccoli, our sprouts, our greens, sweet potatoes. These all have very good amounts. Our carotenoids, and these are organic pigment from plants, but we need to consume it. We can't produce it ourselves. 2 types, and I've mentioned them because you'll see a lot of these on the market. I'm just showing this one. I have no claim, or I'm not getting paid any money, but there's hundreds, I'm sure, of supplements on the market, but that's just one. These have got xanthophylls and carotene in them, and the xanthophylls contain what's called lutein and zeaxanthin, and again these have this already is in concentration at the macula, and we need to increase that concentration at least, or again ensure that the macula has been fed and restored. It's a bit like wearing a pair of sunglasses to protect for the sun. The macula, the macular pigment density needs to be strengthened up like we would with any other part of our body. And we can strengthen that up via nutrients, and I'll talk to you in a moment. Those who struggle with putting a bunch of these on their plate once a day may need to go to these, if we see fit, or if you see fit. But as I've said, the nutrients that we can get, this lutein and zeaxanthin, that's very high quality, is pretty much what I put here. I just thought last night I'd put a box together. You say kale to people, and it's always a bit difficult to know to cook with kale, is it really? I don't know if you find that. So you kind of want to think, well, what am I going to do? I can't have kale every night. So it's trying to make it a bit fun, isn't it? And I'm not going to do a cooking expedition here because I can't. But you want, there's other things out there. There's kale, there's spinach, put a bit of broccoli, a bit of colour. I think just add lots to your plate. It's lots of things. It's not about, because if you start having one thing, I know you'll think, I'm never going to be able to do this. So it's a mixture of just about everything. And you can add some fruits in there, some papaya and stuff that you mightn't have heard of, an apple and all different things that we can enjoy. People say, how often should I take them? Tell me, should I take nutrients? If we look into the eye and we see it looks pretty healthy, that there's no significant changes, that it looks fairly normal, and then we can have a little chat about how your diet is running, then nutrients you can go without. The other side of the coin, you might say, well, hold on here, I've got a strong family history of degeneration. I'd like to do something. But I'm not overly keen. I don't like cooking. I don't like doing all that sort of stuff. Then I think you could say, yes, take a supplement. It has the lutein and the zeaxanthin there, and just obviously make sure if you're having any issues or side effects, then stop taking it. So yes, you can take. How much should I take? Well, 0.8 milligrams is the recommended daily amount. What does that mean? Well, they always seem to give it in cupfuls, don't they? And so they said about 4 cupfuls. You need about 4 cupfuls of a good quality greens a day to get it in. But if you have a bit of mix of everything, you're going in the right direction. And that's really it. So I think it's having a good portion of everything, and a good variety is what's needed. So don't be hung up on, am I taking the right amount? Am I not? I think just having that broad amount there would be really helpful. I've mentioned about supplements. How about supplements? Well, there was a study, for those of you who want to read, there was 2 studies. One called the AREDS 1, and that was followed up quite a few years later by the AREDS 2 report. And the AREDS 2 has given guidance, the public can read it easily, but also guidance to us clinicians on the levels of degeneration in the eye as to when we should recommend supplements. And I think I've summarized in what I've said just there. You know, tends to be at medium levels of degeneration that is where the recommendation is, and that's pretty much how it stands locally as well. We do know that if you're at that level, or if there's a risk, and I think if you believe in the antioxidant theory, that supplements or good nutrition will hopefully maintain the degeneration from changing, and may even improve it a little bit. But definitely, if we can maintain it from changing up the way, getting worse, then that's good. And I think that's how to look at it. There are clinical trials. Sorry, that came out small. I'm very sorry. Yeah, that's just the tip for you all to have an eye test. But no, sorry about that. I'm going to have to squint down here to see this myself. There are trials going on all the time. You may hear about them or read about them. There was some success at Moorfields in 2018 where they did a stem cell trial where they placed a patch of retinal pigment epithelium that was derived from stem cells, and they managed to improve vision significantly in 2 patients in Moorfields in 2018. That was very promising. I think was giving us a lot of hope, and I think there's just a little bit of a funding issue there from the company that was involved in that one. So hopefully that will get back on track, because I think that's probably one of the best ones. Gene therapy was another one where the virus is released and it opens up within the damaged cell within the retina, and then the cell then makes the protein and starts to make improvements within the retina. So gene therapy is one. Another treatment, kind of coming back to the antioxidant treatment, is using energized oxygen. And I'm just going to squint down to look, sorry. Spirovital was the name of the people the product that was involved in. And that's basically like wearing a mask. You have energized oxygen, and you put that on for 20 minutes every day, and that boosts the antioxidants, not just obviously within the eye, but you can imagine, as I said to you, as inflammation is throughout the body, it can improve the general, it boosts the general antioxidant within the body. Again, you don't know how much of this works and doesn't work, but I think, again, if you believe in that theory that ensuring we keep antioxidants high, these things are probably, all these things are worthwhile in their own right. Of course, for those that the vision has gone very weak, there are support groups out there. Low vision clinics here at our hospital for those who have got very weak vision. We have a local charity here, Insight, which provides magnifiers, provides advice, and again, they're excellent. You've all possibly heard of the Macular Disease Society, and again, they're very good for those always interested in trials. They give news updates. They do give information all the time what's going on, so they do try to keep abreast. And again, they're very good, and not always for the person who's suffering, but they can be very helpful for the carers as well, because to understand what that person is going through, what's going on, and what changes are occurring. And that's it. That's my whirlwind run through on macular degeneration today.
Do you automatically get it in both eyes?
You do normally get it in both eyes. Yes, you do. Yeah, very rare not to see it in both.
At the same time?
No, it'll often be different in both. Yes, some people will get it both quite often, and thankfully it's worse in one eye than another. You'll often find someone will unfortunately develop wet in one, and then the other will still be okay, or they'll develop severe degeneration in one that'll affect the vision, and the other will have it but not as bad. It is unfortunate. There's another type of dry degeneration that can affect both and tends to affect both quite badly, and we call that geographical atrophy. It really does affect the central part of the vision. Those people suffer significantly with their vision, and that's far more debilitating than wet will ever be, and far more debilitating than significant dry. That nearly skips the stage. It just goes straight to that really that stage. That's one that tends to be in both eyes. That one, geographical atrophy. Yeah.
The question I had was smoking, not a non-smoker, but is there a cut-off point? I mean, if you stop smoking, does it correct?
It can revert. We can see improvements. It's a good question. That yes, you can see some reversibility there. Yeah. Yeah. Stopping smoking is definitely the answer, and you can start seeing improvements. Yes. Yeah.
All your contact lenses, they all got UV protection?
Yeah, quite most of them have now. Yeah, pretty much. Yeah, I'd have to look at your notes to put me on the spot there. I'm pretty sure they do, but yeah, most of them do now. But yeah, most of them do. Yeah, Thank you. I'll make a heads up on that one. Yeah. Oh yes, yeah, absolutely. Yes, you can. Majority of the glasses anyway will absorb quite a bit of the UV, but you can add more to it if you wish. But we're quite lucky that the lenses that we wear have a lot of UV. Yes, it can. It will give you a certain level of protection as well. Yeah. Obviously, the improving the extra scatter and the blue light and all of that is where the polarized and the sunglasses come in. That works quite well.
Young children, I'm just thinking of that generation, can you spot it much earlier now, or is it something that will occur and then it's there, rather than being able to monitor it? I know you said about history, but...
I think history is important. I think because the technology is improving a lot, and we're going to see it improving even more, you know, and then it could be if there's really strong family history and we understand the genes. I think that's where gene therapy is really going to come in, isn't it? That's how we're going to see changes occurring. So yes, I think at the moment using technology to help us is, I find, good. So you know, put OCT, making sure we're using OCT technology on all our age groups all the way up. Yeah, is really useful, and then taking a good history and watching out for that. Yeah.
So in addition to sunlight, there's a mention of blue light.
Yeah.
Smartphones, computers, etc.
Yes.
So should you limit that, or do you think that the UV protection we talked about is having the same effect if you're reading?
Yeah. The blue light coming off screens is not nearly as much as we think. That affects other parts of our like melatonin levels and things like that. There was a big talk about that some years ago. I think they realised that the exposure, the blue light coming off is very minimal. It's very, very minimal. Yeah, good point though, yeah.
A family member has wet macular degeneration.
Yeah.
Is there a bigger likelihood of another family member developing wet as opposed to dry?
Well, because dry can head to wet, then you know, yes, but whether they'll develop the wet is another story. But we know as most dry leads to wet, then if they develop dry, they may then get wet like their relative did. But not always the case, not always the case, you know. And again, I think it's about education now, isn't it? Being aware of letting them know, and then just letting them know that there are hopefully some preventative things we should be looking at and watching that. Yeah. Sorry,
I have a family member that does have it. I'm trying to find out from my sister whether it's wet or dry.
Yeah.
But when I go for an eye test, should I be mentioning that, or is that a test that's already happening?
It's a test that's normally happening. Sometimes we'll say, my standard question is any family history of eye disease such as degeneration or glaucoma tends to be my question, so we'll often ask it. If it's omitted to be asked, you would have thought when we're looking in at your retina, we will have a look out for that as well, so they should pick up on it. Then they may, if they notice it, if you're young, they may say, oh actually, then they might come back at it and say, oh, is there a family history of degeneration because I've just spotted some changes in the eyes.